All right, I think we are at the top of the hour, so we'll go ahead and get started. And thank you all so much for joining us on this beautiful Friday. And we have a lot of updates to share, and also going to feature a presentation from Dr. Simon Paul, Health Officer for Madera County, my good friend and colleague. So I'm excited. Hopefully you can see my slide deck. We will also send these out as a PDF after the session. I'll start with metrics. A lot of these are taken from the state call that we had on Wednesday. But if you have any questions, I'm happy to try to answer them or elevate them to the state epidemiologists. Overall, the surge is losing its momentum here in California. I think that's shown here, where the number of cases per day really dropped off, even though the area in the yellow is incomplete data, because that information is still coming in. It really does look like, for the most part, statewide, we've hit a peak, and then we're now on the decline for new cases. And we seem to be kind of peaking, slowing, plateauing, declining a little bit for hospitalizations as well, which is shown in this orange line down here. And it's really hard to see the ICU numbers here because of the scales. What Dr. Pan with the state epidemiology team really wanted to stress, she showed this 2 weeks in a row, is that, this is not just the flu. They have statistics that are going back all the way to 2017, where they really track deaths by flu, by pneumonia, by ARDS diagnosis, and COVID is basically dwarfing all of those. And you can see COVID in the red lines here. The flu is the orange line here, which seems to be really flat, although you can see sort of waves here that are kind of buried under the other lines of seasonal deaths related to flu season. That's why we always message about this. That's why I always push the vaccines every fall, because every winter we do have a spike in COVID, in flu deaths. Same with pneumonia, but as you can see, COVID just dwarfs that in terms of the number of deaths that it has caused ever since it came around. And it's anyone's guess how bad the Omicron surge will be in terms of death count. We know that the death count is going to continue to rise throughout the month of February statewide. Here's a really good graphic. You've seen this before, but this is the most updated graphic about cases, hospitalizations, and deaths based on vaccinated status. So here, people that are not vaccinated are really representing the lion's share of cases, hospitalizations, and deaths, whereas those who are vaccinated and really those who are boosted are very well protected. And that's been evident really for a long time, but it's still evident even in light of the Omicron surge, which we know is a little bit taking advantage of the fact that the vaccines and the boosters aren't as protective. And that's why you see, like, way back in the fall, really the vaccines and the boosters were really protective, like for hospitalizations, for deaths. You can sort of see that protection kind of dropped off. And so you did get an increase in the number of hospitalizations and deaths, although it's still a lot less than people who are not vaccinated at all. So again, that just really highlights what we've been saying all along, which is get your shots, get your boosters. It's really still the best strategy and probably the strongest layer of protection that we have right now, aside from the PPE. And I'll talk more about PPE and masking in a little while. Vaccine effectiveness, again, I think this is it says the same thing. It's just a different way to look at it in terms of what's going on. And Dr. Paul, whenever he does his presentation about his original research from Madera, we'll talk more about this situation. Statewide, here's just a little bit drilling down into the different scenarios of cases and hospitalizations. Again, this paints a pretty rosy picture that, we're past the peak and we're on the decline. But remember, this is what the state epidemiologists are seeing statewide. Breaking it up by region, the picture is a little less rosy. You can see Bay Area, Greater Sacramento, Northern California, Southern California are all really clearly past their peaks. With San Joaquin Valley, we're really still at the very top of our surge, and we tend to plateau instead of coming straight down. That's what happened with our last surge with the Delta variant. And so it's really hard for us to say that we are past our peak. We're really hoping that we are, but it's going to take a few more weeks to figure that out. Right now, it just seems like we're in a holding pattern at a very, very, very high level of the number of cases. Here's the numbers in case you're curious or want to share this with your staff in some way. Basically, this is looking at the percent of ICU available, which again, whenever that drops down below 10%, that's one of the metrics for going into crisis care standards. And you can see that really San Joaquin Valley, which is where we are in the Central Valley, we're really having some red flags here because our ICU availability is way less. I mean, it's less than 10%, and in some days it's way less than 10%. And then they also look at something called the current census over baseline utilization, which again is kind of a problematic metric because our baseline utilization in the Central Valley really has not been good and healthy for like the last 15 years, I would say. We just have impacted hospitals all the time. And so our baseline utilization is really a deceptive metric because even that is like not a comfortable place. But now we're even more above that baseline utilization. We're 37% over that baseline utilization. Again, the highest in the state. Percent of COVID patients that are positive in our hospitals, highest in the state. One out of every three tests that we do in our hospitalized population comes back positive for COVID. The only glimmer of good news that I can share with you is that our R effective seems to be now under 1, and it has been under 1 for several days now. So I really feel confident in saying that transmission is slowing, even though that may not be showing up at the level of the hospitals yet. Transmission does seem to be slowing statewide and in the counties represented by the blue area here, which is the San Joaquin Valley regional county consortium. In terms of what's going on with the cases, again, here the number of new cases seems to be coming down per day, although it's super high for Fresno. And here is a better graphic about what's going on with our hospitals. So here today we have 611 or so patients in our hospitals. It seems to be almost as high as last winter's surge. And definitely higher than the Delta surge, which again plateaued right here that you can see between July and October of last year. So we're, if that happens again, that plateauing, that's going to be, just an additional challenge throughout the month of February and beyond. So we really hope that it comes straight down as fast as possible. Here's what the projections are on the CalCat website, which is that we are going to have a slow decline through the month of February, and that we are probably at our height. And that's what most of the models are predicting. There's one model that always seems to be, frankly, quite wrong because it's been wrong since for the last week or so. But that basically predicts a very pessimistic view where we will keep climbing. And I don't think that that's very accurate. The other models kind of agree that we're going to have a downward trend through the month of February for both hospitalizations, which are seen at the top, and ICU numbers, which are seen at the bottom. So hopefully that's a little bit of good news. I know it doesn't feel that way when you're working in the hospitals. I worked 2 shifts earlier this week, so I get that, we're strained in many different ways. And really just moving forward, for those of you that are in leadership positions, please talk to your teams about how do we tell the story of what's going on at the level of the hospitals and the clinics that's not just COVID. I mean, all of these numbers are all COVID numbers, and that's what the public sees. They're not seeing everything else. They're not really seeing graphical representations of just how busy the hospitals are, even outside of COVID. And I think that we've done an okay job with sharing all of our COVID statistics, but we need to do better with sharing just how busy hospitals are with everything else and how strained they are whenever these surges come around, because it's not just COVID. And I know that everyone on this call appreciates that, but I think that the general public doesn't understand that, our healthcare system serves everyone regardless of what they have. And these resources really have to be rationed very carefully for COVID and non-COVID illnesses. So sorry to get on my soapbox there. So here's the summary from the state. Hospitalizations are decreasing. The San Joaquin Valley continues to be impacted. BA2 prevalence is increasing globally. So I'm going to share a little bit of information about that in a couple of slides. But this new variant that you might have read about. It's being detected across the state, but we haven't had any cases that I'm aware of in Fresno County. And I don't know if Simon has heard about any in Madera County, but they look at wastewater surveillance. We're doing genomic sequencing with our swabs. And we haven't seen this variant pop up yet in our county, but it might. It's being seen across the state and definitely in Europe and Southeast Asia. The booster uptake is slowing. So again, vaccine eligibility is, vaccine demand is very low compared to where it should be. And that's very concerning because we're still trying to get vaccines out to people as much as we can. And then cases and hospitalizations currently predict a return to pre-Omicron numbers in March. But I wouldn't say mission accomplished or celebrate too soon, because like I said, especially for the Central Valley, we may still have a pretty hard February, and it's anyone's guess what will happen beyond that. What is BA2? Well, this was actually, it's not even a new Omicron variant. It was actually defined and described by the South African researchers who found the original Omicron. They actually found something they called BA1, BA2, and BA3. It just turns out that BA1 is the one that really took off all over the world. And then they really thought that BA2 and BA3 were just going to be unsuccessful variants. But then in more recent weeks, the BA2 is now being seen all over Europe, India, Southeast Asia. Like I said, no cases reported in Fresno yet, very few cases in California. We're not even sure how much concern to really invest in this variant. It acts very similarly to Omicron. It might be a little bit more contagious. It's certainly going to cause very similar symptomatology from what we understand. Treatments won't change whether, whether the person has COVID related to Omicron BA1 or Omicron BA2. So it really does seem to be an epidemiological oddity that people are tracking, but clinically, I'm not sure that it's going to make that much of a difference. If you want to read more about it, there's some good links that I've been able to share here that you can do a deeper dive with. And if we get more information or better information, I'll share that out. But right now, it just seems to be, yes, we know about it, we're studying it, and we're seeing what it does in other countries. What it's doing in other countries is it's really just being seen all over, and it's being seen in increasing numbers in some countries. Like I said, Denmark seems to have a pretty strong signal. Sweden, India, and Southeast Asia seem to have pretty strong signals. California seems to have a few cases, but not that many. And the UK really seems to be having a late bloom of this variant. And so that's kind of interesting. Let me talk a little bit about COVID in kids, because there's things that we need to know, and there's things that were shared by the Benioff Children's Hospital in the Bay Area that I think are pretty important and interesting. So COVID-19 really is a childhood illness. I think that this is an underappreciated dimension of COVID. And as time goes on, we're seeing more and more kids being affected. It's actually causing 4 times as many deaths as the influenza does in the pediatric age group. There's been 280 deaths in the US under 4 years old. There's an 11 times higher risk of hospitalization in unvaccinated kids. And so vaccinations are definitely protective in this age group as well. But unfortunately, 65% of kids that are eligible are not vaccinated. And this is actually way disproportionate in communities of color, in our poor neighborhoods compared to our more affluent neighborhoods. So again, all this talk about equity that we've been having, this doesn't seem to be getting into the actions and the outcomes that we're seeing in our most vulnerable populations. And it's really something that all of us need to be aware of and start working on, because otherwise we're going to see more and more tragedies in this age group. And at this point, ages 5 and over are all eligible. So let's get them vaccinated. This should be like another standard childhood vaccination that you offer, that you give to kids, that if you're not giving, that you just have that conversation with families and parents that you're treating, or among your staff and your neighbors, and just get the word out that this is just another thing that kids need to be vaccinated against, like measles, mumps, rubella, and everything else that we've left far behind because we vaccinate against those diseases. In fact, the FDA is so concerned about this that they actually asked the drug company to apply for the EUA, which is like it's like the first time ever the FDA has asked that of a drug company, but that's basically what they did. They went to Pfizer and said, look, we really need you to speed up your application. Obviously, don't cut any corners with the trial, but you really need to be prepared to apply as soon as you have data that passes muster. And so by mid-February is when the first hearings about this will be for that under 5 age group, so that they too can be qualified to get the EUA. Here's what's going on statewide. You've seen a version of this graphic before in terms of the admissions. It's just going way up, especially since December, which is when this Omicron surge started. This is what's going on in the Fresno Madera hospitals. And as you can see, this very much tracks with the statewide trends, where we have a lot of kids being hospitalized in the ICU and non-ICU setting compared to before. Across the US, same thing. There was a Delta bump, but now there's an Omicron surge, and the number of hospitalizations is really straining even the children's hospitals at this point, which has really never happened with any of the other surges before from our understanding. But now it's like this really is ramping up their volumes and creating staffing shortages, et cetera. I know some of my pediatric colleagues out there might have some qualifying comments to that, and I welcome those. The death rate has remained low, but cumulatively, there's been over 1,200 kids under the age of 18, including several in Fresno County that we're aware of. And so this is, like I said, very much a childhood illness and a severe childhood illness in some cases. And that's why all the more reason to get kids vaccinated and really get the population protected as much as possible. The Benioff Children's Hospital, like I said, did a town hall and they shared this information out. So I basically decided to use it here. And this is basically showing that vaccines are very protected in their age group. People that are vaccinated and boosted make up a very small percentage of their ICU vented and non-vented population, as well as their acute care population. People that aren't vaccinated, unfortunately, they're seeing a lot more numbers just month after month, and especially with the Omicron surge. So again, in the same way that the general population is very much protected by vaccines and boosters, the same is holding true for the pediatric age population as well. Now, all of this is basically in the background of a larger conversation, which is like, where do we go from here? You know, assuming that the Omicron wave is starting to crest and perhaps come down, and that this surge might be behind us in about 2 to 4 weeks for the most part. Where do we go from here? You know, we still have kids in school that are wearing masks. We still have rather restrictive policies related to quarantine, isolation, distancing, et cetera. Like, how are we going to pivot to a more normal state of affairs? That has to be a very carefully calibrated step-by-step process. So I really like this slide because they start with the Swiss cheese model, which I really like. I've shared this before. They've added the variants as little mice that are eating holes in the Swiss cheese model, which I love. And then they're asking the question, how do we actually step away from having all of these layers of protection, which we know do cause some restrictions and obviously cause a lot of animosity. And I think that they very wisely said, look, we must remove layers in strategic steps. It has to be based on operational and epidemiological factors and prioritize continuous and equitable access. And they basically didn't cite this, but I think that, they're really talking about when are kids going to stop wearing masks in school, for example? When are we going to do something different with keeping kids out of school or closing classrooms, et cetera? I wanted to just drop this in the middle of that conversation because it just came out today. This is an MMWR based in California. They basically went back and interviewed people that had COVID and then people that ended up not having COVID. And then basically asking, how much masking do you do? And what they were able to find is that, the masks really are protective. They had an odds ratio of 0.44, meaning that basically if you wear a mask, your odds of getting COVID are about half. And depending on what kind of mask you wear, those odds actually went down to about 1/5 if you used an N95. And I think that is shown here on this slide. Sorry that the graphic doesn't come out too good, but basically the more high quality mask that you wear, the lower your odds of testing positive for COVID. And this is kind of how the Benioff presentation ended, which is that we have to strike a balance between returning to normal and really just providing equitable, high quality care to especially our most vulnerable populations. And this is not easy. This is just a really hard conversation to have and a really hard set of decisions that have to be made. And we need to have a lot more dialogue. And hopefully civil dialogue about how to move forward, because there's no perfect set of data to guide us, and we just need to make rational decisions based on what our values are and what our risk thresholds are. So I just wanted to end that section with this nice, I think this really summarizes. There's some of us that are early adopters. There's others who are not as ready to make changes in how we're doing stuff. And all of these have to go into this equation. And then I linked a nice article from The Atlantic that just talked about parenting during the pandemic and all of the different strains and stresses that parents are going through. Just, asking what is the end game here? When will all this be over? And when can we go back to normal, if at all? Let me finish up this last section, and then I think we'll take some questions and answers, and then I'll let Dr. Simon Paul proceed with his presentation. In terms of therapeutic updates, we got an email this week, and I think, I could talk about this for a long time too, but basically all of these winter storms that we're glad we're not having on this beautiful day in Fresno are actually affecting what's going on here. And that's just because all of these products that we rely on have to be shipped from the East Coast in some cases, and all of those supply lines are being interrupted. So sotrovimab, Evusheld, Paxlovid, and molnupiravir are all being interrupted by these snowstorms and ice storms that have caused various different supply lines to get held up. And so you may notice, if you are part of the chain of handling these medications and having to distribute them and administer them, that things might get slowed down or disrupted. And that's just because, unfortunately, of these storms that have come through. So I know that I do get on my climate change soapbox a lot. I'm not going to do that, but just let you know I could, and just talk about how climate change is affecting healthcare delivery. Okay, in terms of what we did order, these will sometime come in. We just don't know exactly when. I checked the map that I'm going to show you earlier this morning, and unfortunately, it looks like they haven't arrived yet. However, this is what we've ordered in terms of the sotrovimab and in terms of the oral antivirals and the Evusheld. I just want to say thank you once again to all of the partners that are helping to make this happen. This really is amazing. We just need to make sure that we keep going by doing rational allocation to our most vulnerable patients to make sure that we're using these as wisely and as effectively as possible. Even though this has been a pretty clumsy rollout, the information flow is getting better. What I've done is link here 2 websites that I really urge you to look at. The first one is from the NIH, and the second one is from the CDPH Therapeutics team. They both have really good information about how to choose patients, how to get involved if you want to be involved in delivering these medications to our patient populations, and lots of other good info. So I hope you take the chance to look at these websites because even though they're again, there's a lot of headaches involved with getting these meds out. It's worth it for all of us to be on the same page. Keep in mind, there's a lot more molnupiravir than there is Paxlovid. So for those of you that are using oral medications, if you run out of Paxlovid, or if your patients are not able to access Paxlovid, keep in mind molnupiravir is still pretty good. And there's very few drug-drug reactions with that medication. So in terms of just patient selection, it may actually be easier, especially if your patients are kind of past their child-rearing years or childbearing years, because fertility seems to be the biggest kind of caveat with the molnupiravir. And there's just tons of that available. So please feel free to try to use that because we actually have pharmacies that are turning away their allocations because they have so much sitting on their shelves and they're not able to get rid of it because no one's writing prescriptions for molnupiravir. So just look into that, think about using it, especially for patients that could benefit if they need oral antivirals. We have a new website for monoclonals. I shared this last week. I just wanted to share it again. Dr. Zweifler and the team are doing a great job keeping this up to date and making sure that we have good information on all the partners that are helping us deliver monoclonal antibodies to patients. And then this website is something that you should really have bookmarked and handy. You can even just put it on your phone as like something on your home page on your phone. But basically, this allows you to punch in the zip code for the patient or the zip code for your clinic and see exactly what's in your area in terms of Evusheld, Molnupiravir, and Paxlovid. So this is what I did this morning. Again, these Paxlovid courses are somewhere in this area. It looks like they're at the United Health Centers, but I'm not sure how they're being allocated. But the rest of the pharmacies right now don't have any Paxlovid, but you can see there's a ton of Molnupiravir still allocated and sitting on the shelves in all of these area pharmacies. And there seem to be a lot of Evusheld courses too, although this number seems a little bit high, so I'm not sure how they're calculating that. But I know that Evusheld is available as well, and that's something that you should consider as pre-exposure prophylaxis for your most vulnerable patients. And they talk about Evusheld in the NIH guidelines that I linked a couple of slides ago. So just remember, this is the website. It's called the Health and Human Services Therapeutics Locator, and it's a federal website that uses HPOP data. It's updated every day, and this is basically the best information that we currently have about who's got what medication. And it really, for every one of these dots, you can click on the dot and it has the name of the pharmacy or the clinic, their address, their phone number. It gives you all of the information that you need to really make good decisions about where to direct your patients. Here's what the NIH is recommending. And basically, due to supply limitations, CDPH is saying, let's stick to just tiers 1 and 2, which is immunocompromised patients and those that have inadequate immune response due to underlying conditions, and those that are unvaccinated at highest risk. Basically anyone over age 75, or if they're over age 65 with additional risk factors. And then tier 2 is unvaccinated individuals that are not included in tier 1, meaning age greater than 65 or even less than 65 with clinical risk factors. So I know that that's a big mouthful. Take a look at the whole document. It's not that long. It's just a couple of pages, and it really lists all of the risk factors that we know are associated with increased morbidity and mortality, and then some of the reasoning for how they broke out the different tiers. But right now, just to keep things consistent, this is what we're recommending as well, and this is what the state is recommending, is that right now only tiers 1 and 2 should be allocated for these oral medications. Okay, next week, we're not going to do a medical update, and that's just because we want to make time for 2 amazing lectures by Dr. Fayed. Dr. Fayed is one of our local treasures. He's an ICU physician, a pulmonology physician, and one of my colleagues at UCSF Fresno. And he basically is doing 2 lectures, one on February 9th about outpatient care of COVID, and one on February 10th, which is inpatient care of COVID. I really, really, really want you to catch both if you can. I've linked to the outpatient care for COVID lecture here. It's going to be next Wednesday at noon. So just make time to look at that. Hopefully they'll record it and archive it. But in the meantime, you can catch it live and ask your questions there. And it's totally free, but you do have to register beforehand. And so that's the registration link for you. I'm so glad Dr. Fayed is doing this. He has so much knowledge and so much expertise. He's somebody that I always just pick his brain and just hear out his thoughts and his reasoning. And I'm so glad he's put together this lecture for our primary care colleagues about outpatient management of COVID and how to really think through some of these really hard decisions. So thank you, Dr. Fayed. Okay, now I can take questions if we have them. Let me just look in the chat. But then I really am so excited to introduce Dr. Simon Paul, who is our Madera County Health Officer, and really just let him talk about a paper that he and his colleagues have been putting together. This is now available as a Med Archive. That's how you say that journal. And then basically he'll talk about really, how they did this research, what it means, and what we can take away in our clinical practice. So I don't know if you're ready, Simon, but thank you so much once again for presenting this information. And please go ahead and take it away. And I can advance the slides if you want. I think your first slide, this is your first slide. So just let me know if you want me to go forward or backward.
Yeah, perfect. So this actually started last summer. We were getting a lot of questions about what's my risk for getting reinfected with COVID. from the public. And obviously knowing the chance of reinfection is kind of an important thing to know about any infectious disease. So we took a quick look at it and it looked like actually people had pretty good protection. However, to do it carefully is kind of tricky because a reinfection rate obviously depends on the rate of the infection in the general community. If there's no cases out there, there's going to be no reinfections. If it's a huge surge, you're going to see a lot of reinfections. So you have to compare it to something. You can compare it to unvaccinated people, but unfortunately, we don't have a great random sample of unvaccinated people who've never had COVID in Madera County. The other group we thought we could compare it to is people who've been vaccinated because we do have decent demographic data on them. And also there are great studies, obviously, comparing vaccinated people to unvaccinated people that are randomized. They're well done. Those are the trials that license the vaccine. So you can compare something to vaccinated people and they, by proxy, have been compared to the unvaccinated group. So that seemed a reasonable thing to compare the reinfection rate to. However, obviously it's tricky. We didn't vaccinate people in random order. We started with older age groups and worked down from there. And vaccinated people over 2021 built up over the summer when there was very little COVID. So we need to compare the same age people, the same time periods when the same variants are floating around. So we did this by comparing people that were matched by age, sex, and zip code. And also we matched them up to line up their date of vaccination with their date of catching COVID to compare those two groups. Next slide. So here's what we had. So from our testing data and vaccine data, you can see we can find three groups out of Madera: 23,000 people who only tested negative, 9,000 people who had had COVID during the year, and 68,000 people who were vaccinated. So first we matched up the people who'd either had COVID or vaccinated for the age, gender, and zip code, and also critically, so they either got COVID or got vaccinated within about a 1 week period of each other. And then we matched those. We were able to find 6,300 people who matched. And that makes sense that you couldn't match everybody because there's a lot of the 9,000 people who had COVID, there's a lot of young people in the first few months of the year. They're not going to have a match in the vaccinated group. So from all those people, about 6,000 matched, we could find 6,000 people who were unvaccinated and never had COVID who also matched for age and gender. So basically what this is you're taking two people and saying, well, one of these people got vaccinated and the other person got COVID on the same day. What happens to them? And on the next slide, the first thing we looked at was mortality. And that's actually a cool thing with our study design because most people compare the rates, but they don't look at what was the cost paid to become post-COVID. So this shows of our 6,000 people, about 93, 94 of them who had COVID actually died in the first 50 or 60 days. So there's a big cost to catching COVID. This is not the way to go about getting immunity if one can find another way to become immune. And that is really happening pretty quickly up front. So then next slide. After that, we looked at the chance of having another positive COVID test. And having another positive COVID test does not necessarily mean reinfected, especially in the first 90 days. We know a PCR test can stay positive for up to 90 days without any signs of reinfection, but we were just curious, how often does that happen? So this shows all of the data from when people finished their isolation or became fully vaccinated 14 days after the second dose for the mRNA vaccines. And you can see there's a lot of positive tests in that first 50 days from people who have had COVID. Probably most of those are not reinfections. And after that, they did great. Vaccinated people, however, is kind of the opposite. Right after you got vaccinated, they had great protection. And after about 6 months, it starts to drop off. And the unvaccinated people obviously had the highest risk of coming down with COVID. Next slide. So then, as I said, the first 90 days doesn't even qualify as a reinfection in most cases. So we decided, let's just look at the after 90 days time period from either being vaccinated or having had COVID. And here you can see that the vaccine starts to drop off at about 6 months from your vaccination date. And the post-COVID group actually has pretty good immunity out to 300 days. And both groups obviously do much better than the unvaccinated group. We also looked at the subset of people who are over age 55 and saw pretty much identical results, except we're down to about 1,000 people. So the confidence intervals are much larger. So that's pretty much where we ended the study. And I think the next slide I show, there's a large article that came out in the MMWR where they compared the incidence of COVID in unvaccinated, vaccinated, and people who had either both hybrid immunity or had had prior COVID. And they saw basically the same thing. The lowest line, the dashed lines, are the people who are post-COVID. And you can say they're doing slightly better than the people who are vaccinated. And everybody is doing great compared to the people who were not vaccinated, which is the top line, which is kind of the bottom line from all of this. And their study is not designed specifically to look at how long does the immunity last, when does it start to wane? But in this study, they also looked at the people who had COVID within 6 months or over 6 months, and they did not see a sign of waning immunity over time, which kind of fits with what we found at all. So as far as what all this means, to me, it's a bit like trying to figure out which is better, seatbelts or airbags. Nobody would choose between the two. Everybody uses both. But if you think back to when airbags were coming out and some people thought seatbelts were perfect and there's no need for airbags, unless you have data showing how well the seatbelts work with or without an airbag, people aren't going to listen to you. So that's kind of my feeling for what happened. A lot of people were asking for this information. All they were getting was that vaccination is better. And they were like, but I want to know how protected I am. So I think this is helpful. It's also somewhat positive that people do have pretty good protection. Obvious caveat is this is through only Delta and ended right before Omicron shows up. So that needs to be redone with Omicron. Actually, I was initially going to put this out before Delta showed up, and everybody said, well, you have to wait and see if it's true for Delta. So now, having waited for that, we have to wait and see if it's true for Omicron. So that's one caveat. And I think the thing just to remember is clearly there's a huge cost to getting COVID, which could be prevented by being vaccinated. Of the 93 or 4 deaths, we estimate about 90 of those people would still be alive if they had been vaccinated. So there's a huge cost to that. However, if people survive, then they do have pretty good immunity, but they could improve it further by getting vaccinated on top of it. And the other issue that needs to be updated with this is not just Omicron, but the effect of boosters, which clearly, as in the slides Ray showed just earlier, shows that if you get boosted, it brings your immunity back up to like the first 6 months of having been vaccinated. So that's where we left it off, and happy to answer any questions.
Yeah, Portia asked in the chat a question that I think you just answered, which is, if you are vaccinated and then get COVID infection, will you then have super immunity? So
yeah, so I think people have the best immunity combined of the two, and whether it matters which one you get first, I don't think anybody's sorted out. Like the slide that's up now, the MMWR slide, hybrid immunity, which is having had both. I don't think they sorted out which one happened first. I think it was just people who had both COVID and been vaccinated. People also ask, if you've had COVID, do you need to get both doses of the vaccine, or is one enough? And there's no answer. One might be enough, but nobody knows. And since there's really no further side effects from the second dose, people recommend just getting both doses like normal, because we know that works, whereas we don't know for certain if one dose would be adequate.
Dr. Paul, this is Dr. Baz. Just a couple of quick observation. From your last slide, it seems like the patients who had the COVID or the vaccine, they were not positive for another 300 days. Am I correct, that assumption? Or they were getting less positive tests?
So this is your probability of staying without a positive test. I'm not, just make sure I answer it correctly. So we started looking at 90 days after either being vaccinated or 90 days after you had COVID. So the green line is if you had COVID from 90 days to 300 days, there's only a like 0.01% chance of testing positive, getting reinfected. Whereas with the vaccine, it was like 0.04, twice, about 2 or 3 times higher. Both groups are really well protected, above 96%. So that's what it shows, is just, and it ended at 300 because that was when the study ended, the longest follow-up.
My question is it possible that the people who had the COVID or the vaccine, they were less likely to get tested versus the people who are unvaccinated, they were getting tested more?
Because,
oh, yeah,
definitely.
Logically, normally we should be losing the antibodies after 4 or 5 months. And some of the studies are showing that you do get positive after 5 or 6 months. This almost shows almost a whole year. So is it possible that the people who are vaccinated, like myself, if I have a little symptom, I probably will not get tested, as compared to if I was not vaccinated, my chances are I'll go and get tested, and that will skew the data.
Yeah, I think there are biases in both ways. Like if you think, if I just had COVID, would I test again if I had mild symptoms? Maybe not. And if I just got vaccinated, would I test again with mild symptoms? Maybe I would. And there's other biases that go in the opposite direction. And my sense is those can make small differences, but not enough to change the overall effect. If we don't match people, if we just look at the entire groups of like 60,000, 9,000, we see the exact same pattern. So the matching didn't whoppingly change things. And the unvaccinated group is probably the least represented, because those are people, we only had demographics on people who only tested negative, and they are different from people who never tested at all. They probably suggest they're at higher risk, our unvaccinated group, than the true unvaccinated population of Madeira, and they're probably more likely to test.
Thank you.
And there's a lot of like employer requirements to test and stuff like that, and school requirements. So I think it gets skewed for reasons other than, you know, if somebody just wants to get a test, for example. This is great.
Thank you.
Yeah, thanks, Dr. Buzz. I guess a question for Dr. Paul and Dr. Buzz. I mean, you know, we've been told that it's not just antibodies, it's also things like memory cells, and T cells. And so getting even antibody levels, it may not give you the whole picture of how immune someone is. Is there any, you know, is there any data or science to that, so that, you know, for example, someone who is showing no antibodies at all, they would still have some immunity because their memory B cells, for example, would be able to generate antibodies in case they got infected?
I mean, I'll start. I mean, I think there has to be more going on than just the antibody levels, because sometimes people say, well, we can't use antibody levels because some people post-COVID don't show much antibody or no antibody at all. It's like, well, something must have happened because they got over the infection, right? So they've got some immunity that isn't showing up as antibody in our tests. And I don't know the data well, but it was actually back to the question that Portia Alexander had asked about having both. There was a study done at Rockefeller where they looked at people who had had both, and they showed they had like great memory cells, or I don't know what else they measured with cellular immunity, showing that they had really persistent immune response having done both. But that's getting out of my area of expertise. And
there are some studies right now, the papers are published, that maybe there is a genetic difference. Some people produce more T cell, memory cell than the other people. My personal observation is, since we have been giving antibodies, that we see significant number of people who are got fully vaccinated, had the booster dose, and that still develop the infection. And then I've seen people who have not vaccinated, they're positive, but hardly have there any symptoms. So, and then there is also some paper published that there may be the other COVID, or not COVID, other coronaviruses may be giving some T cells and giving immunity. So I think it's all over the place. We do not know, but definitely there are some people who do have some T cell immunity and who do not react. Who are they? I don't think anybody knows at this point, and there are very controversial papers are published all over the place.
oh, that was it. So 2-3 things. That was the other reason for this study, is there's a lot of secondary markers like that, antibody levels, and it's like, it'd be good to have clinical data on the risks of reinfection and vaccine breakthrough until there are better correlates. But the other thing, back to Dr. Baz's earlier question about who's more likely to test, the other bias is who's more likely to use mitigation measures. So my guess is post-COVID people are probably a bit less likely to test, but from the people I've met, they're also less likely to be wearing masks. So the less likely to test would make them look better, the less likely to wear masks than the vaccine group, who are concerned and wearing masks and doing everything right so as not to catch COVID. Those two biases kind of work in the opposite direction. So there are biases, but my guess is they're small and a lot of them kind of cancel each other out.
So let me ask the question that I think is the elephant in the room, which is that, have we been unfair to people that have natural immunity? Have we been, you know, not really accounting for their protection based on their natural immunity whenever we ask people for their vaccination status, for example? Shouldn't we also ask for their post-COVID status, because this data shows that they're pretty well protected for almost a year? I know that that's hard to document just based on like what's, you know, how are you going to check their antibody levels, et cetera. But what do you guys think?
Yeah, I kind of agree to some extent. I mean, the US has really lagged in that. A lot of other, you know, we have this 90-day pretty much exclusion. For 90 days after having COVID, you don't have to test and you're considered protected. In most of Europe, it's considered 6 months. In Israel, if you have documented infection, you get your green pass, so you can go into everything. And I think it's good for 6 months. So I don't think this shows people are immune forever, but it suggests instead of 90 days, it could easily be 6 months, right? And it wasn't necessarily intentional. We have the data now. You know, maybe we should have had the data a bit sooner. This data isn't that hard to get, and maybe it should have been 6 months or 9 months instead of 90 days. But it's not like going to totally change the recommendations. Obviously, it's still much safer to get vaccinated. The biggest downside is when people who are unvaccinated skip the mortality slide, right? And they think, oh, if I catch COVID, I'll have great natural immunity. I was like, yeah, but there's a huge upfront cost in mortality with that. So to me, that's the biggest issue that gets neglected. But yeah, frankly, if somebody had COVID, I think you could say for 6 months, they should be getting the same pass as somebody who's been vaccinated. But again, and I think we were heading in that direction, but Omicron, kind of all bets were off until we get data on Omicron is the other factor.
Yeah.
Except that famous tennis player lost it. He had a COVID and they didn't allow him to participate in the tennis games, the Australia Open. So,
Right.
I agree with Dr. Paul. I think there's a lot needs to be done on that direction, but I think we are a little behind the curve.
Mhm. Any other questions or comments from the rest of the group? This is a great discussion. Thank you both so much.
Thank you.
Wonderful. All right, well, we're going to send out this slide deck. And like I said, we've hyperlinked to the paper that Dr. Paul, and I think your son was one of the co-authors, and Paul Mills. So that's so fantastic. This is a really great project, and hopefully you'll keep updating us as you get more information and push the science forward with how to look at post-COVID protection versus vaccine protection. Thank you so much.
Great, thanks for the chance.
Yeah. Okay, well, remember to sign up for Dr. Fayed's lectures next week. We're going to hyperlink to the registration site for that. Otherwise, have a fantastic weekend. I also just want to say a special thank you and good luck to Rick Lembo. I don't know where you are, Rick, but Rick is going to start another adventure. You can unmute and tell everybody about it if you want, or I can brag on your behalf. But he has accepted just an amazing position with, I think it's the Miami Dolphins, where he's going to be doing sports medicine with the Miami Dolphins and helping manage their medical team. So he'll actually be bi-coastal for a while because his family is still based here. But I just want to say congratulations on that amazing promotion. And thank you for all of the great work you've been doing at SPOC, the Sierra Pacific Orthopedics Clinic, which has been like a real partner for the health department and helped us in so many different ways throughout our testing and vaccination and other treatment modalities. So I just want to say thank you to you and to your SPOC partners and good luck and happy adventuring in your next chapter. And I'll just leave it at that.
Thanks, Dr. Vohra. I appreciate it. It's been a pleasure. Without interacting with you guys, probably wouldn't have been the opportunity that I have now. So thank you very much for all the learning and just being a part of it.
Well, I remember when you had to go like isolate in a hotel because you had COVID and you were still checking in with our phone calls and our media sessions. So I really commend you for all of your hard work through all of our pandemic trials and tribulations. Thank you so much.
Yeah, thank you. My wife sent me to the Hilton to keep the cooties out of the house. So, and that's when we thought of the idea of, hey, let's do a drive-through.
I remember that. Okay, great. Well, if there's no other questions or comments, I think we'll go ahead and adjourn. And we're happy to take any more questions or suggestions as they come up. And in the meantime, look out for the PDF of all of these slides. And we'll see you all, not next week with this update, but a week from next week for further updates. Thank you so much.